charge pending. Oh, so okay, yeah, I'll restart here. So this is a 73-year-old woman. She was admitted for failure to thrive, and she was discharged pending that morning. So the team had asked that we go see this patient first, and she was waiting to be transitioned to a different care location, basically waiting for an expedited outpatient G-tube placement. And so you go and do kind of discovery rounds. And you pre-charted on the patient, but because all the patients are new and there's like 13 or 14 patients, they're kind of all running together. And so and also the resident team is new. It's, they've only been on the service for 1 to 2 days. So you ask them just to give you some overnight vitals and like the most recent labs. So for the vital signs, the patient has been afebrile. The blood pressure has ranged from 99 to 127 systolic, over 49 to 85 diastolic. The heart rate has ranged from 84 to 90. The respiratory rate 14 to 18. And then the patient is satting 93 to 100% on room air. And then as far as the kind of basic blood work that we had, the patient's sodium was 132, potassium of 3.4, chloride of 99, bicarb of 32. There's a BUN of 40, a creatinine of 0.25, and then a glucose of 90. And then for the liver tests, and don't worry, I'll paste all these in the chat. But for the liver tests, the AST was 30, the ALT was 30, the alkaline phosphatase was 40, the albumin was 2.7, the total protein was 5.2, and then the bilirubin was 0.4. And then finally for the CBC, the white blood cell count was 1.06 with an ANC of 1100, and then an absolute lymphocyte count of 200 with a normal being greater than 900. The hemoglobin was 5.6 and the platelets were 130. And so that's the first aliquot. And I hope to give you the same overwhelming feeling that I felt in the moment when I was taking care of this patient.
I'm there, Austin. I'm freaking out thinking, why did I offer to moonlight this weekend? This is so hard. Um, I guess let me just share a couple thoughts and then Zaven, I'll let you maybe jump in on some clinical perspective first, but I just want to acknowledge up front what you went through, Austin, right? Covering new team, someone ready for discharge, and then Mark, what you said just about failure to thrive as a way to package a patient. I hope we can all see that as a diagnostic call to arms, right? Why is someone not gaining weight or not able to eat, right? There's an underlying diagnosis there, and really just feeling challenged to actually figure out what it is. I'll just acknowledge up front, as any physician taking over a patient where the inertia is towards discharge, recognizing there are a lot of kind of real life pressures on shortening hospital stays and opening up hospital beds for new people. The ability to look at a case and say, this is not right, is an important one. It's sort of like a stop the line instinct, to take a phrase from manufacturing. But in this older woman who's not been eating well such that she needs a G-tube, who has pancytopenia and a way out of proportion kind of BUN elevation of creatinine, I'm just sort of pulling the brakes in many aspects right now, just hearing the opening. Zaven, I'm sure you have even more kind of sophisticated things, but I wanted to get that emotional reaction out, both on how complex this already is and how hard it is when someone is being lined up to leave the hospital for their next phase of care, to just say, hold the phone here. That's such an important thing for us to do.
Thanks, Steph. Yeah, totally agree. And I think I would also just acknowledge the potential emotions of, I guess it was a new resident team. So maybe this makes it easier, right? But I find myself doing this sometimes whenever I come on service and there's an existing resident team and their existing plan, right? And whenever you're just sort of messing with that, certainly if you're pulling a handbrake and turning this train 180 degrees around, you know, you kind of want to acknowledge that that's distressing, right? It kind of creates uncertainty and to really justify in a patient-centered way, like, hey, it may just be that I don't know enough yet about this patient, and we'll rely on you guys to maybe fill me in. But from what I've heard so far, like, I just need to know more because you know what, something we certainly haven't heard yet from Austin is any diagnosis, right? And this woman, sometimes when people are losing weight, I use this term to kind of create some drama. Like when people unintentional weight loss is slowly dying, right? So this woman is slowly dying, and we don't know why. And you know, maybe all the efforts have been made to try to figure it out. But I just need to catch up with what those have been. And that's what I'm hoping Austin will tell us, right? But we need some sort of, you know, history, context, background, all that. But you know, the problem list so far is already many, right? It seems to be unintentional weight loss. It's certainly profound pancytopenia. Wow, you know, especially the red and white cell lines, but also the platelets. And and then there's maybe also and you know the BUN. I don't know if that reflects renal dysfunction. I don't know if that reflects you know a hypercatabolic state sort of active muscle breakdown. And um, I don't know if that reflects, I don't know if this patient has a feeding tube, a temporary feeding tube, if not a G tube for now, then she's being hyperalimented and that's why it's elevated. I don't know if she's on steroids, but like that's certainly that there's and the creatinine of 0.25, especially with that BUN, just reflects what we're likely to see on physical exam, which is just profound cachexia and, you know, and loss of muscle mass. So so there's a lot of concerning things that we need to work on figuring it out. But Steph, I share your um, uh, empathy for what for what Austin had to, excuse me, do in real life on this Saturday morning, which is both to try to, you know, help the patient, but also, you know, take his teammates with him and not make them feel like, you know, he was causing them unnecessary pain.
Yeah, amazing thoughts. And yeah, not to spend too much more time on it, but probably the BUN elevation was multifactorial, but had attributed it to the tube feeds and hyperalimentation, as you guys alluded to. But yeah, you sort of hear these numbers and you're like, oh my goodness. And so you pull up your notes that you pre-charted the night before, and you wrote down that she has a medical history of type 2 diabetes and hypothyroidism, and she was admitted 2 weeks prior for just progressive decline in functional status and poor PO intake. And they had a outpatient G-tube placement scheduled, but they just didn't feel like they'd be able to make it to that appointment without more significant decline, so presented for care. Um, and so over the last I guess they basically thought that, you know, she'd been admitted a couple of times over the last 8 months for small bowel obstructions. And she had had a couple of XLAPs, with the last surgery being about 6 weeks prior. And so this is what they had sort of attributed her decline to. So we go in to see the patient, and she's kind of sleepy, so she's not able to really interact with us too much. But the nurse says that she's overall looking stable, and the tube feeds that were going were stopped overnight because she developed some abdominal discomfort and vomiting. Um, and so moving to the physical exam, generally, as you guys suggested, or you know, thought she's kind of thin and wasted appearing, very frail. She had a weight of 41 kilograms and a BMI of 17. Head and neck exam, she had the NG tube in place. Cardiac exam, there was no murmurs. The heart was regular rate and rhythm. The lungs were clear with normal work of breathing. And for her abdominal exam, she was soft. There wasn't any obvious tenderness. She was mildly distended. And then she had well-healed kind of surgical incisions from her recent surgeries. And then for her extremity exam, her legs were warm. And then she had probably like 3+ edema extending up to her thighs and then even into her sacrum and abdominal wall. And then for a neurologic exam, didn't do anything thorough, but generally she was sleepy but arousable. She could follow simple commands, and then she was alert and oriented ×2. And I'll just stop for your general reflections there.
Thanks, Austin. A lot more helpful info. As we were hearing more story, I was thinking about how to start reframing her case, and really we're helping to figure out an older woman with recurrent small bowel obstructions. Sounds like we may or may not right now know the original etiology for that, with ongoing, perhaps pain and vomiting from persistent motility issues, again with this pancytopenia with predominant lymphopenia layered on top. Maybe, Zaven, I'll just sort of think about unpacking from an internist perspective causes of recurrent small bowel obstruction. And I don't know if you want to help layer on the sort of pancytopenia on top to see if we can get this all fixing together. But I think recurrent small bowel obstructions, I think, well, first of all, small bowel obstruction can happen because there is an extrinsic cause for compression or blockage. And most commonly, that would be adhesions from prior surgeries or prior inflammatory disease, like an IBD with Crohn's. External could also include things like, peritoneal disease and carcinomatosis. But is there something extrinsic to the gut, intrinsic to the gut wall itself, like a tumor, or something in the lumen of the bowel whose wall is okay, but that is causing problems? And that's where things like having impacted like a foreign body or anything actually intraluminal. So extrinsic, intrinsic to the wall of the gut, and then intraluminal as well. And again, I think hearing about her recurrent obstructions, we'd want to first ask about prior surgical history, because certainly adhesions and then complications of subsequent surgeries themselves would be the most likely cause of that. But presumably through her workup, she's had kind of a thorough evaluation with scans and such for luminal, intraluminal, or kind of wall-related pathology. So my thought would be that epidemiologically, adhesions and scarring likely kind of explain for these recurrent obstructive processes.
Very nice, Steph. Yeah, I think this might have been on like a VMR or RLR or something that I learned from Robbie, just how he thinks about kind of SBO, and there's big dichotomy between whether someone's had prior abdominal surgery and not. Where if they have, like, that's it almost every time. But if they haven't and they're having essentially an SBO phenotype, like, that's really weird. And I love the kind of organized differential you offered. And some of the things you mentioned are things that go places, right? And kind of go into organs, whether that's malignancy or kind of infiltrative proteins or infiltrative infections. And one of those other places that they can go is the bone marrow, and to cause pancytopenia. I think like a silly, easy thing not to miss, though, I always try to be sensitive of like kind of consequential complications of a primary process that then causes, a sort of signature elsewhere, where, you don't necessarily think of pancytopenia as a consequence of small bowel adenocarcinoma, but it can be once it causes such profound malnutrition that you just don't have, the B12 and copper and other things that it takes to make cells. So I think looking at a smear, checking for nutritional deficiencies and treating them empirically, and same, by the way, goes as far as her mental status. And sort of edema, sort of nutritional state, optimizing it and looking for kind of complications of malnutrition and treating them is important, both in and of itself, but also to take some of these other problems out of the picture if they're not actually part of a syndrome that you need to work on to actually figure out like the primary disorder. Um, so yeah, that's how I'm kind of thinking about layering on the pancytopenia, just to summarize, like, is it nutritional? Because there's risk for that. And then if not, kind of actually thinking about bone marrow infiltration essentially as a unifying diagnosis potentially with the abdominal syndrome. Um, yeah, I mean, are there other kind of inflammatory disorders that can cause both the abdominal syndrome and kind of peripheral cell destruction and dysfunction? Yeah, but I think it seems a little less fitting to me for now. Um, I'm missing a lot in the chat. Does anybody want to comment or emphasize anything else from the chat or keeping up? Yeah, Ethan, I like that thought. And yeah, like the albumin 2.6 is low, but not horribly low. She does seem kind of immobilized, where dependent edema in a patient like this would be not surprising, but like pitting to the abdomen, especially if it's anterior abdomen, it kind of crossed my mind too, that is there sort of capillary hyperpermeability as part of a systemic inflammatory disorder. Although a lot of the stuff we've mentioned, it would be kind of non-specific even if there were. Mhm. Okay, Austin, you want to keep us moving?
Yes, no, incredible thoughts. So yeah, just to kind of we kind of get out of the room and I sort of create that initial problem list like you guys do, and I just start asking them a little bit more questions. So why the pancytopenia? And so basically the team, up to this point that we're taking care of her had attributed to vitamin deficiencies. And so just given all of her bowel issues that she had been experiencing, but when you go and look at the results in the computer, she had some iron studies. Those were basically normal. She had a vitamin D, a zinc, a vitamin A, a vitamin B12. All of those were normal. She did have a thiamine level that was checked that was low, but that was earlier in her admission and that had already been kind of replaced. Um, and then even after replacing that, there wasn't any clear improvement in her counts. If anything, things had been getting worse, and they've just been giving her blood transfusions as needed. And then there was no obvious bleeding that had been kind of commented on that they found. There was no haptoglobin that had been checked to that point, but an LDH and the bilirubin, as talked about before, were normal. There wasn't any clear signs of hemolysis. The retic count was low, consistent with some sort of bone marrow process happening. And then I looked back and they had done HIV and viral hepatitis screenings earlier in the mission, and all of those were negative. So at that moment in time, that was kind of like the working thought for the pancytopenia. And then to what I had framed as like anasarca, why is this lady anasarchic? And so that had been attributed to hypoalbuminemia and then third spacing just related to her multiple hospitalizations, as you guys talked about. But there was also some concern of like an occult malignancy, like in particular, like some sort of luminal cancer within the GI tract. And so, but you sort of step back to the fundamentals of edema and you look back, and this lady had actually never had an echocardiogram done before. She had never had a urinalysis or urine protein creatinine ratio. And then she had had cross-sectional imaging, but actually never had any dedicated imaging of her liver. And then they had kind of queried her cancer screenings. She was up to date, like on her mammogram. But then as far as the scopes go, they actually were in consultation with GI about doing a upper and lower endoscopy to look for things, but that hadn't quite happened yet. And then to complicate things even more, they ended up checking some tumor markers during her stay, and a CA 125 was like markedly elevated, like above the upper limit of detection. And so they actually consulted GYN while she was in the hospital to look for any sort of gynecologic malignancies. And there was nothing seen on the CT scans that she had before, but they ended up doing like a transvaginal ultrasound, which ultimately, for reasons that we'll get into, like it was just non-diagnostic. So that was kind of their thoughts on the anasarca. And then finally, to round out the altered mental status, they had just attributed it to delirium. It seems like the patient had been kind of waxing and waning. In fact, was like more alert yesterday when they had seen the patient when I wasn't yet on service. And then her last like thyroid, to Zavin's point, was a TSH was 12 with the normal T4, but actually it was like 30 with a very low free T4 earlier in the mission. They'd actually just started her on IV levothyroxine with some improvement. And then earlier in the admission, they had gotten a CT head, and that was unrevealing. There was no acute findings. So that was just like our general assessment of like in that moment what the working hypotheses were. And so just based off everything, as you said, I said, hey, I just don't have a great understanding what's happening. Like, I just don't think we can discharge this patient right now until we get some more tests. And so some of those things that hadn't been done, I'd asked them to order those things. And so we finished rounding, and then later in the evening, I got around to during my attestations to try to kind of read up a bit more about the patient. And so for kind of filling out some of the southwest corner, so for medical history, diabetes, as we talked about, her last A1C was right around 7. And we don't have any information on like her previous level of control or complications from diabetes. And then the hypothyroidism, as I mentioned. Her other medical history included high blood pressure. And she actually been off all her home blood pressure medications during this admission. And when you go back and look at her vitals from her previous admissions, her blood pressures were generally ranging from like the 130s to 140s systolic over kind of 50s to 60s diastolic. So it definitely had downtrended overall compared to her previous admissions. And otherwise, her medical history is just pertinent for like being a former smoker. She had like a 50-pack year history. And then to the surgical history, which you guys had asked about before. So she had multiple prior abdominal surgeries. She had a C-section, and then she had a cholecystectomy as well. And then a little bit more about her XLAP and kind of lysis and adhesions that she had. So the first one that she had done was about 10 months ago. And then the most recent one, as we talked about before, was about 6 weeks prior to when I met the patient. And so unfortunately, we don't have any information at that point about like her initial admission, because I was at a neighboring hospital system. But in the admission, a month-ish ago, it sounds like she presented with sort of acute on chronic progressive, like postprandial abdominal pain and bloating, as well as nausea and vomiting, and a weight loss of about 40 pounds over the last year. At that last admission, they had attempted to manage the SBO with medically, just with the NG2, but they were unsuccessful. So they took the patient to the operating room. They saw dilated bowel, but they didn't see an obvious transition point. They had a lot of adhesions, so they did lyse a lot of adhesions, but there wasn't any obvious or distinct transition point that they found. And then so she was admitted for like a couple of weeks. Eventually she discharged, but then within a couple of weeks she represented to this current admission that she's at right now. So that's just a little bit more, a little bit more information. So you don't need to summarize. You don't need to talk about too much about like our general thoughts. I just wanted to lay that out for you. But just if there's anything about the past medical history and the surgical history that helps you make progress or rethink about what's happening right now, is what I would like you guys to focus on.
I'll just make one comment and turn it over to Steph, which is that I think this surgical history for this problem is really important, like, and specifically the actual op reports, or if there's any way to kind of talk to the surgeons, because when people do an XLAP or lysis of adhesions, whatever, for they they see the peritoneum, right? And they run the bowel with their fingers. And so if there was, ovarian cancer that had sort of peritoneal metastases, which is what it would have to have done in order to cause this, GI luminal syndrome, um, or if there was, a large intermittently obstructing, intra-small bowel mass like a lymphoma or a rare, jejunal adeno or something like that. Um, a lot of times the surgeons would have felt it. So I think seeing those reports would be helpful, but the fact that she had multiple of these surgeries and that no diagnosis was made, to me, I think shift this a little bit more towards either kind of like a diffusely infiltrative process um, of the bowel or a neuropathic process of the bowel. Um, and anyway, so I think that that sort of surgical history was super helpful to hear, Austin. And if it does, I think, sort of reprioritize just a little bit potentially.
Yeah, very helpful. The only comment I'll make is, as was hearing sort of the subacute to chronic symptoms leading to the first surgical intervention, in the context of a woman now with anasarca, which could be related to, as we said, kind of malnutrition and just lack of mobility. But I am trying to kind of build my illness script and think about how just the general category of protein losing enteropathies fit here. And I'll just say I'm, starting to think about like, is there a gut problem here that's leading to protein loss? And that protein loss happens because either the mucosa is permeable or loss of lymphatic liquid is happening. So I'll just sort of say explicitly, I've just been thinking a little bit about sort of the overlay of conditions that could be at play here, causing obstructions, causing anasarca, causing malnutrition in that category of primary gut disorders that lead to protein loss. I don't know if we'll sort of go down that pathway, but I've been just thinking a little bit about that category and what I do and don't know about it.
I think to that point, Steph, I'd also just circle back to what Austin said, which is like she had been consulted or planning scopes, whatever. I think no matter what needs to be done for this patient, um, as the hospitalist, as the generalist, as the primary kind of caregiver, I would just be going all out trying to, help consultants, others see what I believe to be like a great urgency here. I think this has been going on for many, many months. We don't have a diagnosis. And by the way, the G tube, like, it doesn't sound like she has any trouble putting food in her stomach, right? The trouble seems to be it's not going through, it's coming back up, whatever. We're trying to feed her now and she's throwing up. So like the G tube here is it's not even a band-aid, you know? Um, so I think yeah, I love that thought, Steph, and just sort of looking inside the organ and assessing the organ that seems to be dysfunctional the best way we know now, which is not cross-sectional imaging, it's endoscopy, right? With biopsies seems to be really, really critical piece that I would try to advocate for ASAP.
Okay, yeah, very good. And so yeah, later in the evening, like after you get home, still things are like not really making sense to you. So you're reviewing things a bit more. And so you have a chance to review the most recent like cross-sectional imaging that the patient had. So earlier in the mission, she had a CT abdomen pelvis with oral and IV contrast. And basically, that showed that the liver, the spleen, the kidneys, the bladder, the uterus and adnexa, the bones, the solid organs, like that were not mentioned right now, like all those seem to be within normal limits. She had her biliary tree looked fine, except it was a little bit dilated, like expected after a cholecystectomy, so nothing too dramatic. She had no lymphadenopathy. was commented on. Vascularly, she had some calcifications that they thought were just sort of like age and risk factor related, but there's no aneurysms or ectasia. And then for her GI tract, which was kind of the meat of the read, so she had a patulous distal esophagus. She had diffuse dilated loops of small bowel with some wall thickening, which they said was stable from a prior CT that she had. And then it seems like her distal small bowel loops in the right lower quadrant were decompressed compared to the more proximal ones. And her large bowel appeared normal. She had a small amount of pneumoperitoneum, which they said was stable from the prior evaluation. And then as far as the oral contrast goes, there was no extravasation of the contrast like outside of the GI lumen. And then she had diffuse ascites and anasarca, which they commented was worse than compared to the prior CT scans that she had done. And then at that time, they also did a CT chest, and it showed bilateral pleural effusions, but no pulmonary edema, no pericardial effusion. They again noted the soft tissue edema that she had, just sort of extending in the upper body, her torso as well. Her heart was normal shape in size, they said, but it had extensive left main and left circumflex artery calcifications with questionable kind of dilation, but they weren't able to get a clear definitive picture because the study was like not dedicated for that. It wasn't a CT. There was no contrast on that particular CT chest. And then they also noted that she had significant valvular calcifications, in particular of the mitral valve. And then the last thing for this aliquot was with the ascites, they had actually done a paracentesis earlier in the mission, and it showed that the cell count was 73 with kind of a normal differential and everything. The cytology was negative for malignant cells. The gram stain and culture were negative. And then the albumin in the fluid was 1.1. And the serum albumin at that time was 2.4. And then she had a total protein in the fluid of less than 2. And then the LDH in the fluid was normal. And I'll have you guys discuss there.
Thanks, Austin. Yeah, I think the sitting down and reviewing the imaging is really helpful in us just defining that the gut is not normal here by function. We knew that from the history, but it doesn't seem kind of normal here radiographically with the kind of dilation suggesting either a motility problem or a problem just with the actual structure and wall of the intestines or both. And then layering on the imaging confirmation of this anasarca. So it just helps us sort of solidify our kind of gut disorder with anasarca. We see these pleural effusions as well as the main driver. Quick question, Austin, when you were saying maybe there was dilation, they meant of the heart is.
No, the heart itself, its size and its shape seemed to be normal, but some of the coronary arteries, particularly the ones that were heavily calcified, so the LAD and the circumflex, they thought might have been slightly ectatic, but they couldn't comment definitively without contrast.
Okay. So I think the imaging review is helpful, right? I think it makes us solidify that kind of getting tissue from endoscopy is going to be very important to look for infiltrative conditions in particular. And then just a comment on the ascites. It sounds like the gradient between the serum and the ascites albumin was over 1.1, suggesting that kind of the portal hypertension sort of categories were most kind of concerning there. Although I was a little bit surprised by that, sort of not having heard reasons thus far for her having kind of post-hepatic, intrahepatic, or pre-hepatic, unless there is a infiltrative process, again, affecting the gut, affecting the bone marrow, that's affecting the liver also, and sort of explaining that pattern. Those are my initial reflections on hearing that. Zaven, what do you want to sort of layer on?
Just one thing I think that I want to make sure we don't miss is actual, cardiac dysfunction. I know the exam when Alec first saw this patient on Saturday morning in a state of what was was unrevealing, but just I think constrictive pericarditis is one condition that can sort of sneak up on you and just present with um, ascites, hepatic dysfunction, swelling, right? Where there's not kind of a clear slam dunk like heart failure syndrome, right? There's not necessarily pulmonary edema. There's the echo might be, I don't know, even normal or normal-ish. And uh, but really, I think evaluating venous pressures closely can probably come close to excluding sort of advanced constrictive physiology. So I don't know if you mentioned her neck veins or and then obviously sometimes you can hear other abnormal heart sounds in the diastolic phase of auscultation. The fact that there's no pericardial effusion on the CT doesn't exclude it. Anyway, so I think that's one thing I would want to make sure not to miss. That could explain a lot of this, except the pancytopenia. Similarly, if we think about that our conversation in the last 20 minutes or so has really been focused on the GI tract, but a lot of the things we're thinking about again don't explain the pancytopenia except through kind of concurrent parallel infiltration. So I just want to kind of refocus us to make sure that we're not losing track of the weight of that and the potential diagnostic value of that. So if we scope her and don't see anything, and the biopsies are still pending or are negative, or if we can't scope her for some reason, I think in parallel potentially sort of pursuing the pancytopenia more aggressively with both a bone marrow biopsy as well as some non-invasive ways to get at the possibility of at least a lymphoid or myeloid malignancy or plasma cell disorder causing both, just in the form of an SPEP and free light chains, in the form of peripheral flow cytometry. I think that would be very appropriate to do while also just thinking about like what's wrong with the gut, what's wrong with the gut.
All right. Yes. No, very good. And so yeah, it's the next day, it's Sunday. Clinically, like she's unchanged. There really isn't anything that's happened. But you're kind of reviewing, what was cooking from yesterday. So the echo that was ordered is still pending, but sounds like, over the weekend they're not gonna be able to do it. So it's probably gonna happen like on Monday. They did check the urine, so UA and the urine protein creatinine ratio, and all of that came back normal. There was no excess protein. There was no signs of inflammation or blood in the urine. Um, Going back to like the first aliquot where the patient had like very profound lymphopenia in the moment, as perplexed and ended up ordering just like a CD4 count, which was less than 40. And I'm not, I'll have to reflect back on why I did that in the moment. I think I had a reason, but I don't exactly recall. And then she did end up getting a liver ultrasound with Doppler. And it showed that she had heterogeneous and coarsened hepatic parenchymal echo texture, which they thought could be secondary to either hepatitis or chronic liver disease, but said to correlate clinically as the radiologists do, and to consider getting an elastography if you wanted some more information. They again saw that she had moderate ascites and right pleural effusion. They were not able to see all of the hepatic vasculature, but for most of the hepatic veins, portal vein and IVC, there was no kind of clots or abnormal flow or anything that they saw. And yeah, so that's the next piece of information. What do you guys think? Oh,
Um,
I forgot to say the spleen was normal in size. It did not seem enlarged.
yeah. I think the liver doesn't look normal, but also doesn't uh either show anything very advanced, right? And just with the pancytopenia, with like the platelets being highest of the threes, the spleen size being normal, like sure, there might be some abnormal flow and a contributor to ascites, but it doesn't seem like it's yeah, it doesn't change too much for me. And even if there was some like, so, more overt kind of hepatic dysfunction involvement, as Steph has said, is a part of the same process, right? So I think it could potentially give us one more target of tissue diagnosis, but wouldn't be my first choice necessarily. And then the CD4 count, I noticed, Alec, you in the first Alec kind of emphasizing those numbers, which by the way didn't add up. The total white count being 1.06, but the absolute counts adding up to at least 1,300. Uh, so maybe those are two different CBCs you were reading off from. But no, I think that didn't catch my eye too much because it's sort of proportional leukopenia, right? There's the neutrophils are down, the lymphocytes are down, and I'm sure the monocytes and like everything else is down. So when you have just profound pancytopenia, leukopenia, like you're gonna be lymphopenic, and that's just sort of it doesn't necessarily point to a lymphocytic kind of disorder. So the CD4 count again had to by definition be probably less than 100, right? Because you have 200 total CD4 plus CD8s, and CD4s are usually less than half. So yeah, I think this person obviously needs an HIV ruled out, but I think very, very non-specific, and both in a chronic leukopenia, severe leukopenia of any etiology, as well as in acute inflammatory infectious states where there's, high cortisol state, relative sort of lympholysis, you're going to have low CD4s, and kind of non-specific to me, but maybe it's part of the clue and I'm just not putting it together well enough here.
No, yeah, thanks for catching my math error. Yes, I was kind of trying to piece. There was so much data. I was trying to like piece together all the different CBCs and everything. So I'll adjust that. Thank you for catching that. But yeah, so basically, so your Sunday's over. You wrote your attestation. You're like, oh, okay. So you're in the clinic the next day. It's Monday. I'm in the afternoon. You kind of go and open up people's charts to see how they're doing, and you see on checking up in her chart that actually in that morning she had a desaturation event where she desaturated to the 70s, and she actually went pulseless, and she was DNR and died.
Mm, terrible.
All right, man.
Yeah, and so I guess in the moment, I wouldn't say I was stunned at what happened, but was really, taken aback and just disappointed about all of the lack of clarity that we had, on the situation, and just sort of the devastation that had come to this person, and for it to end in that way, and the the family was, just incredibly grateful for the care that she got and had a really like prolonged and difficult course, up to this point. But the team that was on that took over, as far as the attending goes, like actually approached the family about an autopsy, and they were amenable to that. So we actually were able to get a lot of diagnostic clarity about what happened. And so I'm going to share the autopsy results. And this is like, I think this is one of the first times I've ever read an autopsy report, but it was like the most incredible piece of medical documentation that I've ever read. And so I will share like a de-identified version in the Academy chat for people that are interested. But to just kind of go through some of the relevant findings that they saw on the autopsy. So her lungs, she had sort of changes secondary to her smoking history, but most pertinent, she had like evidence of acute right upper lobe pneumonia, consistent with an aspiration event that unfortunately led to her demise. And then there was no clear evidence of malignancy anywhere that they could see. Her uterus and her adnexa were actually surgically absent, so they weren't even present, despite all of the evaluation that she had, and even commenting on the CT multiple times that the uterus was normal and that the adnexa were normal. And I have to say that's actually a phenomenon that I have seen multiple times. And then it's not uncommon that people are not entirely certain what parts of their body were removed, particularly, going back many years ago where we didn't necessarily have as good informed consent as we do now, but that they were actually absent. Her liver showed congestive hepatopathy, that's how they described it, but there was no significant fibrosis that they saw. And then in her esophagus, there was severe distal erosive esophagitis. And then as far as going to the bowel, actually her entire small bowel, so duodenum, jejunum, ileum, her colon, and her rectum were diffusely dark and ischemic. And then sort of what they commented on, the major finding of the autopsy was that she had markedly severe calcification of her mitral valve, which likely resulted in abnormal functioning, like probably mitral stenosis. But as we had no echocardiogram to correlate, like they couldn't say definitively. But it seemed like with the amount of calcification that she had, it was even there was changes of the heart around the valve such that there was probably ischemic damage in that area, which made them very suspicious that there was some malfunctioning. Additionally, the left atrium was quite dilated. They didn't see any clots in there, but basically based off of what they found on the heart and the distribution of the gut ischemia that they saw, their leading hypothesis was that she had severe ischemic bowel disease from thromboembolism, probably related to cardiac disease that was unrecognized. So they weren't able to find clots like within the mesenteric vessels. They looked at the SMA and stuff, but from their reflection, they couldn't definitively exclude that. And so those were kind of the main takeaways from the autopsy. I'm not sure where your thoughts are about how to piece all things together, and then I'll give my reflections at the end. That's the end of the case.
So helpful to see kind of what was there on histopathology to piece it together. I hear that with just some uncertainty. It's interesting that if this was I guess they were saying primary thromboembolic from that mitral valve. I guess I'm surprised there wasn't more of a predominant syndrome of cardiac dysfunction before the gut dysfunction was there. That's what's sort of striking to me. Of course, right? Bad heart failure can lead to a lot of gut issues. It's just interesting to me that that's what presented first. And a question I have, or I would ask the pathologist, is with such diffuse ischemia of the bowel without any macrothrombus being seen, is there any chance it was more small vessel related disease as opposed to macro vessel disease to explain the whole territory of her gut lumen being ischemic? It just seems like a lot of territory for some clots to cover. So those are sort of my uncertainties and questions I would probably want to chat with the pathologist about to understand better what was the initial cause of all of this.
Yeah, no, amazing reflections. And yeah, I don't think this gives us all of the answers by any means. But the way that, well, I'll share something that I did, and then I'll go back and give you my final reflections. But, after this happened, probably a year or so passed. And then we were during one of the academy sessions or VMRs that Zaven was alluding to before. I learned about the role of ischemia and how we wouldn't want to miss that in people that present with small bowel obstructions. And so this lady, since we never found any clear transition point, she had risk factors, but since we never found any, the possibility of ischemia came back into my mind. So I kind of revisited this case, and I went back and I was able to find the records from the first hospitalization that she had at the neighboring hospital. And I was able to review the documentation that was sent to us. And so basically at that time, she really presented and was able to provide the history herself that she had like significant food avoidance, because every time that she would eat, she would develop significant abdominal pain and consequent nausea and vomiting. And so at that time, the team there was, appropriately concerned for mesenteric ischemia. So they did a CTA and it showed mesenteric atherosclerosis diffusely, though it only resulted in kind of mild stenoses nothing that made it particularly obstructive, it seemed like, and there wasn't any thromboses that they saw at that moment in time. But it sounds like they tried to manage medically, then eventually took her to the OR just like before, lysed some adhesions, but didn't find any clear transition point. There, I saw that her CBC at the time of her discharge from there, she was her white count, her platelets, all those were normal. She was just anemic at that moment in time. And then they actually did an EGD and colonoscopy during that admission, and she had severe erosive esophagitis distally, and so was placed on a PPI at that time. And then a colonoscopy was completely unrevealing. They didn't see anything at all. So how I was piecing everything together, I think unfortunately this patient had chronic mesenteric ischemia, had ischemic events that led to small bowel obstructions, and then had progressive some level of chronic mesenteric ischemia that led to protein losing enteropathy, as Steph has commented before, which was probably the explanation for the pancytopenia in part, though unfortunately they didn't do a bone marrow assessment on the autopsy. I'm not sure how reliable that is, or if that's even possible. I'm not sure if that, and I'm just not certain of that, to be honest. And maybe there was like an endocrinologic aspect to her pancytopenia as well. That is still a little bit hard to clear, but certainly protein lesion enteropathy can contribute to pancytopenia related to vitamin and nutrient deficiencies. And the tests that we have for vitamin and nutrient deficiencies are not particularly good. So just because they were normal doesn't mean that her stores or where they needed to be were actually appropriate. And so again, it was probably multifactorial. I'm not really sure. But as far as the gut ischemia, she had some amount of ischemia that was there for the whole time. And then I'm thinking that she developed some amount of cardiac dysfunction. Her blood pressures had gone down. So she had relative ischemia to her gut. And it just to progress to the point that she ended up developing such devastation in her abdomen. And then the sort of issues which she had with alimentation were related in part to the esophagitis, which I don't think we had a clear explanation for. They did biopsy at that time. There was no cancer. There was no H. pylori. I'm not sure if there could have been an ischemic component to that area as well. I'm not really sure. But unfortunately, there was no immunoglobulins that was done. There was no lipid panel. There was no alpha-1 antitrypsin in the stool done. There was no SPEP done to look for capillary leak, as people were talking about. There was no cholesterol or triglycerides in the acidic fluid to look for chylous ascites or anything like that. It didn't appear to be chylous ascites as far as milky appearance, but it doesn't have to be to have chylous ascites. And they only tapped it one time. And then there was never any discussion about doing a bone marrow biopsy or anything like that. So yeah, just wanted to share this case as just sort of a reflection of how devastation can happen from ischemia, and how the diagnostic thought train and getting on this train can really lead you astray on a time course that isn't necessarily what you would expect. And I think this is the challenge when you come in and you take care of patients. It's very easy to say, hey, this is the way it is. This patient's discharge pending. Like, I don't know what's happening, but let's send her out. But as soon as I saw this patient, I was like, dude, nothing makes sense. Like, you didn't get an echo. You didn't get, like, I don't understand anything that's happening here. And I kind of left out some more details, if you can believe it, to make it a little bit more simple. But this patient had actually been approached to, like, for palliative care in hospitals. Like, we literally have no clue, like, what's wrong with this person. Like, how can we even give them any information about what to do? But in the end, it arrived at probably a bunch of diagnoses that I wouldn't say are particularly esoteric. Certainly some of them can be difficult to diagnose. And I did find case reports of chronic mesenteric ischemia presenting as protein losing enteropathy. But I just liked the aspect of the hospital medicine taking over patients. And I know you both have had experiences, and my brother has certainly shared with me experiences where you take over a team and people have different perceptions of how the patient's care is going and what they want to be. And there's always competing perspectives about, like, hospital discharges and everything like that. But this was a very memorable case for me. And thank you so much for putting up with it, since it was a difficult and long and prolonged case. So.
Thank you, Austin.
Austin.
Yes. Oh, go ahead, Zaven. Sorry.
Just wanted to say sorry again that our patient didn't get better, but I think your efforts weren't wasted. I think. Thank you for teaching us and helping us learn from her journey today. But I'm sure that even just the kind of modeling and advocating for her and for our ideal of striving to solve problems and understand and learn made a lasting impact on the people you're working with that weekend too. So thanks for sharing the case with us, and have a lot more to reflect on. Some things medical, some things existential, honestly, but really appreciate you bringing a case.
Ditto. Thank you.
Sime, do you want to highlight just a couple of the stuff that you you parsed out in the teaching points, and we can adjourn?
Yes, thank you so much, Steph and Zaven, for the discussion. And Austin, it was great learning from the case, but also learning the importance of advocating for our patients. And it was just amazing how you explained such a complicated case with so much clarity and with all the awesome teaching and being mindful of everyone's time. I think I'll just share my one favorite poll. All are my favorite, but I'll just share one, being mindful of everyone's time. So, when the patient has a small bowel obstruction, we can think about either something extrinsic, such as there might be some adhesion or scarring secondary to a surgery, or something intrinsic, such as a foreign body or ischemia, as we had in this case. And thank you, everyone, for your time, and really enjoyed today's session. Sad for the patient, but learned the importance of advocating for our patients.
Sime, thanks again, everybody. Have a great day.
Thanks, everyone. Thanks again, Austin. Really learned a lot. Have a great Wednesday, everyone. Bye.